Good morning, ladies and gentlemen. My name is Rodney Mutunji, and we are going to look at health information management systems. And today we are introducing a topic called health data. So, as public health officials, we need to be very well versed with information management systems because we realize that our interventions, either in the community or on individuals, has to be evidence based, and the evidence we get it from this data that is collected very well, that is very well organized and uh, and analyzed in a correct manner. So from the collection, it has to be very well done, and we need to always inform the people that are going to collect this data on how to collect it very well and make it in a way that it can be useful whenever we are going to roll out our intervention. So today we are going to see what health data is, the sources of that health data, how we can collect it, how we can make it look good, and and helpful to our interventions, and the challenges that we can meet here and there. And then later on, we shall see how to really do it practically. So, health data by definition refers to the information that is related to various aspects of health, the healthcare services, the individual's health related behaviors and characteristics. And it will include data that can be collected from individuals, like I said, healthcare providers, healthcare facilities, and public health organizations. So, all these can be sources of the data that we are calling health data. So we look at types and sources of this health data. It can be collected from the health facility, or what we have termed here as health services based sources, which will be either routine or periodic. So if it is collected from the health facility, then it could be during service delivery, or it could be uh, in periodic assessments of this self-service delivery system, or it can be from disease monitoring and surveillance, because there are diseases that we need to keep on tracking so that their numbers do not go beyond the expected, and then we have epidemics developing without knowing. So those are the diseases that form the surveillance systems, and from such systems we get essential data, which we have termed as health data, and it is from the health services based source. So another source can be population based, where we do surveys, maybe from research surveys. It can be in form of censuses, like a population census, where you count all the people, their property, and you get the social demographic characteristics of them, the sex, the occupation, the economic activity they are engaged in. And then another population based source can be the vital registrations, where we look at births, the deaths, the marriages, and all those vital registrations, and all these provide data on community outcomes and impacts of health service delivery. So first we shall expound more on health services based sources, and then later on we can look at the population based sources. So the data collected routinely during this health service delivery forms what we have called the health services based sources, and it includes information that is collected as part of regular health services, such as the patient records in those healthcare facilities. So when you go to visit a clinic, a hospital, there is that information that you give to them. It could be name, it could be your sex, it could be your occupation, it could be where you're coming from. All that information is what we have called the patient records. Then it could also, this health services based source information or data could be collected via periodic assessments, or not on a regular basis, but periodic, like after a month, after a week. There could be this data that is collected, which involves assessments conducted at intervals. So the intervals are what I've talked about, either after a month, either after 2 months, either after half a year, to evaluate the performance and effectiveness of the health service delivery systems. And data collected, it can also be from disease monitoring and surveillance, like I said in the previous slide, which focuses on tracking and monitoring specific diseases, including notifications and surveillance systems. So, like I said, we want to focus on those diseases that we don't want to get into a situation of epidemics without knowing. For example, if we know that malaria cases in in a specific region shouldn't go beyond 30, so using such notification and surveillance systems, we can always notify the stakeholders whenever the cases go beyond 30, so that they can put in place measures to control such an epidemic. Then another source could be primary health facility treatment records and hospital-based treatment records, which are essential data sources. So the primary health facilities could be those first line health facilities, like those local clinics, like those records by community health workers who provide that health those services at community level. So the records that they have, for example, from those village health teams, and even the records in the hospitals, those that get referrals from these primary health facilities, are what we can use as data sources, which form the health services based sources. So health services based sources could include those that are collected routinely, like the patient records. It could include those that are the data that is collected on a periodic basis, like after a month, after a year, after half a year. Then that data that can also be collected for monitoring and surveillance, like for those diseases that are epidemic prone, like malaria, in cases of sub-Saharan Africa or the tropics where it is common, and then that primary health treatment records. So the primary health facility treatment records provide information on health and disease patterns in the community. It also gives us information on the utilization level of these health services, the drug consumption by the members of a community that is served by that primary health facility. Then it could also give information about the effectiveness of the primary health interventions, because if primary health interventions have been put in place to counteract some specific disease, and then you see numbers are increasing in the public health facility, meaning that the effectiveness of that intervention is questionable. So we use such data to analyze and assess whether the effectiveness is whether primary health interventions are effective or not. Then the cost of interventions and revenue generated. Some of these primary health facilities could have some services be private or paid for, so that revenue that is generated is also factored in whenever we are assessing these records. Then human resource requirements, to know whether the human resource that is available is what the community that is being served by that primary health facility deserves. Then materials and equipment utilized and needed. We also can get that information from these records. Then from hospitals or the referral points of these primary health facilities, we can get information that is also essential to make decisions. And these hospitals could be government or private. And then we realize that from such records, we get insights into the effectiveness of health interventions in the community. Like I said, if you have put in place interventions to, for example, prevent or control malaria, but you see the numbers are increasing in the hospitals or from the records that are in the hospitals, then you know that there is something wrong with your intervention. So it informs you on what measures that you should put in place, or it triggers you to make a survey on how to improve your intervention so as to reduce those numbers of malaria cases. So the data from these hospitals can direct us on, or it always gives us insights on health and disease patterns in the community, how people are utilizing the health services, the drugs that they are consuming, the types of those drugs that are dispensed, effectiveness of primary health interventions, like we have talked about, the cost of interventions and the revenue that is generated from those services that have been privatized or they are paid by individuals who access these hospitals, then the human resource requirements, and then materials and equipment that is utilized during health service delivery, and then those that are needed. So another source of data is what we called health and disease surveillance. And this involves systematic epidemiological data collection to track disease incidence and or prevalence trends. So when you look at epidemiology, we are talking about the distribution, the determinants, and then the trends of diseases. And in incidence, we are looking at the new cases of a particular disease, while in prevalence, we focus on those new and old cases. So if you're looking at a month, for example, this June, the new cases of malaria in June will form what we call the incidence of malaria. But when we look at the old cases and the new cases, for example, those cases from the month of January, February through to June, all those form what we call the prevalence. So the new and old cases are what we call prevalence, and then the only the new cases are what we are calling the incidence. So when we systematically do collection of this data of the new and the old cases, then we are going to be achieving what we call surveillance. So surveillance data will be collected from health facilities or the community or at community level and is aggregated to arrive at national and subnational estimates of the diseases that we are interested in. Another source of data is the health facility assessment, which is a systematic investigation that is conducted in health facilities to ascertain the capacity of the health facility, availability of health services, and the quality of those services that are delivered. So it can be done through surveys, can be done through censuses and qualitative assessments to collect data on infrastructure, staffing, services, and management systems. Here we want to use qualitative assessments because we want to see how satisfied are the staff, how satisfied are the patients that are visiting these health facilities, and this satisfaction can be better measured when you use qualitative methods of data collection. Yeah, because they will give you in-depth, that in-depth feel of information rather than that which can be collected from quantitative. So we tend to utilize qualitative assessments when we are collecting this data that has been termed as health facility assessment. So from this health facility assessment, we can gain data about the quality and the availability of services, location of service delivery points in that health facility. We need to know where maternal and child health services are delivered, adolescent services are delivered, laboratory services are delivered, outpatient services are delivered. So we need to know the location of those services in a particular health facility. Then the types of services that are available. We also gain data about quantity and frequency of services, how often are services delivered. For example, if we are looking at non-communicable diseases and we are focusing on diabetes and hypertension, we need to know in a week how often are you giving these health talks to these people who are having diabetes mellitus and hypertension. So that is what we are calling the quantity and frequency of services. Then the staffing is very essential. We need to know the numbers. Are the numbers enough for the patients who are visiting this health facility? You know, what is the doctor to patient ratio? It's very, very essential. And then the qualifications, are they do they have the expertise to meet the needs of that health facility? You know, if we are going to conduct cesarean sections in that health facility, do you have the qualified staff to do that? You know, do you have the medical doctors? Do you have the anesthetist, those who provide anesthetic uh, uh, drugs in that facility so that you can do the C-section very well? Then the staffing patterns is also a very essential component of this data that we get from health facility assessment. Then the quality of services, we looked at that. The support mechanisms, which include the building conditions, the equipment, and the supplies. And this includes things like gloves, you know, the supplies like those that are used in treatment of these patients, the drugs, you know, the IV lines, and everything that can aid the, the effective treatment of someone who is ill. Then the tools that are used in routine health data collection and reporting could include community-based summary forms, which can be utilized by the community health workers, and then health facility community outreach forms whenever a health facility organizes an outreach, for example, to go and do routine immunization in the community. They always use these forms to document whatever they have done. Then the National Health Management Information System summary forms is more of the general form that includes all these other forms. Then we also have health facility based forms, which could include outpatient, inpatient, and all the forms that are used to collect data and aggregate it so that it aids in good reporting of these conditions and whatever they have done in that health facility. So the tools that are used in health disease surveillance, one of them includes the integrated disease surveillance and response tool, or what we have called the IDSR. And this is further divided into weekly reporting forms and monthly reporting forms. We also have outbreak investigation forms. So in weekly reporting forms, we collect data on diseases of public health importance, including those which are epidemic prone. For example, in our case, we have diseases like cholera, malaria, and then those which are vaccine preventable, for example, measles, polio, and other priority conditions. So from the weekly reporting forms, we get those monthly reporting forms, which are generated based on the weekly reports, and they provide an overview of disease trends and surveillance activities. So you want to think of these monthly reports as the summary of those weekly reporting forms. So if you have your 4 weeks of reporting about malaria, so now we want to use this monthly reporting form to make an average of the disease, of the cases of malaria in that month. Okay, so we want to know how many cases of malaria, for example, have been in the month of May. So we use this monthly reporting form to do that. Then the outbreak investigation form will document and investigate disease outbreaks, including information on the affected population, the clinical symptoms of that disease in question, the laboratory results, and response measures that have been put in place to control and put in check that disease. Then another tool that is used in health disease surveillance is what we call the EWAS, or what is the early warning and response system tool. So the early warning and response tool has also the weekly reporting form and the monthly reporting form, and similar to the integrated disease surveillance and response tool, it utilizes this weekly reporting form to collect data on epidemic prone diseases, for example, malaria, cholera, and other diseases, and then other health events of public health concern. So it depends on the country, depends on the setting, which diseases are of interest, and these are reported through such forms. So the early warning and response system tool also has the monthly reporting form, which summarizes the data collected through the weekly reports and provides that comprehensive analysis of the disease trends and response activities that have been put in place to control the spread of that disease. And then alert and response tool facilitates the rapid response to the disease alerts, including the case investigation, where you're going to look at uh, how the case presents, where it is, which population is affected, and then you want to do contact tracing of those people who have been in contact with the people who already have that disease, and then implementation of control measures is also documented using this EWAS alert and response tool, because we want to know which measures have been put in place, and then we can always look back and see, are those measures being effective in controlling this particular disease? Okay, if they are not, which others can be put in place without repeating those which are not effective? Yeah, so that is the essence of recording or reporting these control measures. Then another tool that is used in health disease surveillance is the immunization data tools, and these include immunization registers, which are used to record and track immunization coverage, and they include uh, administration of vaccines and the vaccination status of individuals. So every individual that is immunized, their records are stored, or they are put into into the system of these immunization registers. Then The other immunization data tool is the vaccine stock card, which helps to monitor the vaccine availability, expiry dates, and the stock levels at health facilities. So, this stock card is always used to tally the vaccines against the original number. So, whenever these people who are handling vaccines or the cold chain team receive these these vaccines, they have to record the number that they have received. And whenever they give out these vaccines, either in the health facility or in an outreach that has been organized by health facility, they need to make sure that they update their stock to know what is available, what has been used, and always be updated. Then the National Immunization Coverage Survey is the one that is conducted periodically to assess the immunization coverage and identify the gaps in vaccination programs so that we put in interventions so to make sure that we cover as much population as possible. Yes, so you only do that by collecting data through these national immunization coverage surveys. Then another tool that is used in health disease surveillance or to monitor diseases and their patterns is the laboratory data tools. So these include the laboratory test request form, which is always by the medical practitioner or that one who receives the patient. So if you receive the patient and they tell you their history, you're going to use this tool to request for a laboratory test. And it could be in diseases like malaria, HIV, and other infectious diseases. And then, after requesting for this laboratory test, then the laboratory people are going to use the laboratory result form to give an overview of what they have found out from the sample taken of this patient. So once the laboratory tests are conducted, the results will be documented using these specific forms, which provide information on the test that has been performed, the results, and sometimes the interpretation. Though in some cases, the interpretation is done by the person who requested for this laboratory test. But in some tests like that one of I've seen the ultrasound tests, they always give an overview of this interpretation. Yeah. And then another tool that is essential in health disease surveillance is the health facility registers and records. And these include the outpatient registers, which capture data on patients visiting the health facilities, including their demographic information, presenting symptoms, diagnosis, and treatment provided. So, patients visiting the health facility do not all end up being admitted. There are some people who visit the health facility, they get treated and go home. So their information is always captured using these outpatient registers, and it captures their demographic information like where they come from, their sex, their occupation, and this data can always be revisited by people who are collecting this data, and it can always be used as a very essential source of data. We need to know, for example, if you need to know the people suffering from malaria, how educated are they? Which occupation is most affected by malaria? You know, so you could maybe discover that a particular occupation is being affected by malaria, and why is that? You want to always probe and discover the reasons that could be causing such a trend. An age group could also be affected by malaria, a particular age group, for example, those children who are under 5, so that it always triggers you to put in place measures to focus on those people who are more affected by malaria. So that is the essence of using such tools. Then the other tool under health facility registers and records is the inpatient registers, which records information on patients admitted to health facilities, including the reasons for admission, the diagnosis or what they are suffering from, the treatment that is administered, and the outcome of that treatment. So when you are admitted, you can expect maybe to get well and be discharged. You can also expect to be referred if that condition cannot be managed at such a health facility, or sometimes, unfortunately, you can expect to die. So that outcome also has to be recorded. So that brings us to also another record, which is called the health registers, and this the death registers. So these death registers document information on deaths occurring within the health facility, including the causes of that death and what could have contributed to the death. And now we also need to focus on selected tools in health facility assessments. So whenever we are conducting the assessment to know the capacity, the quality of services that are being offered in health facilities, we can always use such tools, and they include service provision assessments of the SPA. We also have service availability mapping or the SAM, and health facility based human resource for health or the HRH assessment. Then we have the rapid health facility assessment, which is always conducted during crisis or during times of disasters. And then we have assessing integration methodology or the AIM tool. And we shall look at each of these individually. So we start with service provision assessment or the SPA. And this is a comprehensive assessment tool that will evaluate the facility's availability, readiness, and the quality of health services. So it assesses various aspects of the service provision, including the infrastructure in place, uh, the equipment used in that health facility, the staffing or the manpower, and the service delivery protocols. And this SPA helps to identify the gaps that exist in a particular health facility in those areas of infrastructure, equipment, staffing, and of course, after identifying these gaps, we also look at the areas for improvement so that the care services can be better. But also, we enable policymakers to make informed decisions to allocate those resources that are needed to fill those gaps that we have identified using this services provision assessment. So, these findings from such an assessment guide the development of strategies to enhance service delivery and improve the overall quality of care in a particular health facility that we have conducted this SPA in. Another tool that is used in health facility assessment is what we have called the SAM or the service availability mapping. And in this case, we use this tool to map and assess the availability of health services across a geographic area that we are interested in. So it collects data on the location, the type, and the accessibility of a health facility and the services that they provide in that health facility. And the mapping exercise helps to identify and understand the areas which are underserved, the gaps in service coverage, and this enables policymakers to prioritize resource allocation in those areas which are underserved and improve access to healthcare. So this sum or the service availability mapping will support evidence-based planning and decision making by clearly understanding the distribution and availability of health services in a given region. So if we are doing mapping in a particular region of South Sudan and we discover that there are gaps in health facilities, or there is a particular place where they have less access to health facilities, or one area is left in the dark when we are talking about access to health facilities, then we influence decision making so that we allocate more resources so that that area has better access to these health facilities, or it also gets a health facility of its own. So this is the essence of using this service availability mapping tool. Then the other tool that we can use to do health facility assessment is what we've called human resource for health assessment, which is always health facility based, and it focuses on assessing healthcare workers availability, the distribution and the capacity in health facilities. So it evaluates the staffing levels, the numbers of these people in that health facility, their qualifications, their skills, the workload on each of them, and the retention strategies. What motivation factors are in place to always retain these health care workers? And then this HRH assessment goes on to provide valuable insights into the capacity of healthcare workforce to deliver this the quality health care and identify the areas that need interventions such as recruitment. So, if you discover that the staffing levels are lower than the required number, then you have to do an intervention on recruitment. And then, if you discover they lack some skills, then you have to focus your your intervention on training. And if you discover that that particular health facility is lacking in supervision, or the workload on the supervisors is a lot, then you focus on supportive supervision by external teams that can always do this support supervision on that health facility. So the findings of this HRH will inform the human resource planning and policy development, strengthen the healthcare workforce, and ensure that there is adequate staffing in health facilities that are in a particular region or area. Then the other tool that is used in health facility assessment is what we have called the rapid health facility assessment, and it is a quick and streamlined assessment that is used to gather essential data on the readiness and functionality of health facilities. So this tool focuses on critical indicators like infrastructure. For example, are we having uh, good buildings? Do we have the good materials that should be used in this health facility? All that. And then the essential equipment, the essential drugs and infection prevention control measures, and availability of basic services. And we do this because it provides that quick snapshot of the overall readiness of health facilities and identifies those immediate priorities for improvement, because we need to do this in a quick fashion. And this RHFA will support the rapid decision making and resource allocation, especially in emergency or crisis, to ensure that we have health facilities that are adequately prepared to deliver essential services. So this rapid health facility assessment is always done in times of emergency. For example, if there is a pandemic like COVID-19, we need to quickly do this assessment on the essential equipment, the essential drugs, the essential infrastructure, so that we identify those gaps in those basic services and we put in place measures to close those gaps or fill those gaps so that these health facilities are ready to face this challenge in the emergency. So it is done in a rapid fashion or in a quick manner to strengthen the capacity of these health facilities in the face of emergencies or crises. Then the last tool that is used in health facility assessment is what we are calling the assessing integration methodology. And it is a comprehensive approach that is used to assess the integration of health services across different programs or levels of care. And it examines the coordination, collaboration, and coherence of services within and across health programs, aiming to achieve better health outcomes through integrated service delivery. So you want to see if we are delivering maternal and child uh, health services, are we integrating nutrition in it so that we deliver a holistic package to these mothers that are attending maybe ANC? They need to know the nutrition, and they need to have nutrition skills. They need to know to have nutrition information so that the children that they are going to raise do not end up being malnourished. So such a tool is going to help us in doing that. So it assesses various dimensions of integration, including governance, financing, service delivery, information systems, and community engagement. There should be collaboration between all these sectors of healthcare provision: the governance, the financing, service delivery, information systems, and community engagement should always work together to have a better healthcare service that is delivered to the community. So this aim provides valuable insights into the effectiveness of integration efforts and helps to identify the barriers and the facilitators to successful integration, which will inform the future program planning and implementation strategies. So in future, you use this data that has been collected using this AIM tool to have better programs and interventions. So let's look at another essential uh, aspect of health data that is called the facility audit. So the facility audit systematically assesses health facilities capacity, infrastructure, services, and management systems. It involves collecting data on various aspects of the facility, including its infrastructure, the staffing levels, the services that are offered, and the support systems like the buildings, the supplies, and all that support quality healthcare provision. So the tools that can be used in this health facility audit include structured questionnaires that could be closed-ended or open-ended. And when we talk about closed-ended, you want to think about those questions that always have answers to them. Like if I ask the question, are you, are you, if I ask the patient a question like, are you getting good 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 healthcare services from this hospital, and then I put the options of yes and no, so that is a closed-ended question. But if I asked the patient to describe the services of to describe the healthcare service of that particular hospital, it will be open-ended and it might help me to get more information from such a patient. So You use such tools, the structured questionnaires, to obtain information on infrastructure, the staffing levels, the services that are offered, the management, and the support systems in place. And they are designed to collect standardized data across different health facilities. Then another tool that can be used in health facility audit is what we call the visual inspection. And this is where sometimes the public health officials come in, where we physically inspect the facility to cross-check the presence and functionality of the resources mentioned in the questionnaires. So from the questionnaires, they might tell you some services like the adolescent clinic, the hypertension clinic, the laboratories. So now in the visual inspection, you want to cross-check, are these services that were mentioned in the questionnaires available? And if they are available, are they functioning? So it includes assessing the facilities infrastructure, the equipment, and other physical aspects. Then the other tools that we use in the facility audit include the patient medical record review, where we review patient records to assess the quality and completeness of documentation, including the diagnosis, treatments, and outcomes. So whenever the patient comes in the hospital, like I said earlier, their information is captured, but it needs to be captured well so that the people who are going to use this information find it easy to use it. So when we do this patient medical record review, we want to ascertain that there is completeness of this documentation. And this review helps to evaluate the accuracy and reliability of health data recorded in patient records. Then another tool is the provider interviewer, and as the name suggests, we use structured questionnaires to obtain information on the people who provide this healthcare service, and we look at their attitudes, their knowledge, their behavior related to health service delivery. So this tool assesses healthcare providers' perspectives on service delivery, the challenges that they face, and opportunities for improvement that can be put in place. Then the other tool or the other method of doing a facility audit could be through observation of provider client interaction, which involves direct observation of healthcare provider client interactions during service delivery. So you could sit somewhere where you can observe this interaction, and then it will help you to assess the adherence to recommended treatment guidelines, the communication skills by these providers or by these medical by these medical teams, and then the overall quality of care through that observation. Then the other tool is exit interviews, which are conducted with clients as they exit or they depart from the facility premises to gather feedback on their experience and satisfaction with the services received. So you could be at the gate to the facility where you sit and collect data from these people who are coming from this health facility in question. So you want to gather information from them on how and whether they are satisfied with the services that they received. So this will provide qualitative insights into clients' perspectives and can help improve areas that need to be improved. So it will help you to identify those gaps that these clients feel need to be improved. Then another key aspect in health data that we cannot go without talking about is electronic health records, or the EHRs, and they are digital versions of patients' medical history, including their diagnosis, their treatments, their medications, and other relevant health information. So whenever all this information is fed into electronic devices, then it forms what we call the electronic health records. And the purpose of these EHRs is to centralize and streamline patient information, making it accessible to healthcare providers and improving patient care while facilitating communication and coordination among healthcare professionals. So, the key benefits and advantages of these electronic health records is that they enable comprehensive and accurate patient records, leading to better diagnosis, treatment decisions, and care coordination between healthcare providers. Then there is always enhanced efficiency because they eliminate the need for manual paperwork, which sometimes can be tiring. They streamline the documentation process and enable faster access to information. Yeah, sometimes using this manual paperwork can not only be tiring but also lead to loss of this information. You might lose some files by either malicious people taking them out or some natural calamities that can, for example, if there is heavy rainfall and this rain or the water that is from this rainfall destroys these files, you might lose vital information. But whenever they are stored in an electronic system, then they are safer and they can be accessed faster. Then the other benefit is increased patient safety. Like I say, they reduce medication errors. They provide alerts for potential drug interactions and enable better monitoring of patient conditions. Yeah. Then data accessibility is electronic health records facilitate easy access to patient information by authorized healthcare providers, ensuring continuity of care across different healthcare settings. Yeah, so you can move from one health facility to another, and your information uh, will just be emailed, or it will just be accessed by authorized healthcare providers in your new healthcare facility very fast using these electronic health records. So the key features and components of these health records, which are electronic, include the patient demographics, which could include the patient identification, the contact information, next of kin, demographics like sex, occupation, and 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 uh, and locate and address, and then the medical history. Then we can also have clinical documentation, including the clinical notes, diagnosis, procedures that were done on the patient, for example, surgeries, and then the treatment plans could be the medication that is being administered to this patient, and other treatment procedures that are going to be administered on this patient. Then medication management offers features for prescribing medications, tracking the prescriptions, and managing drug interactions. Then the other features and components of these electronic health records include the laboratory and test results. They are also always a vital component on these electronic health records. And here they store and display laboratory test results, imaging reports, for example, from X-rays, the CT scans, the ultrasounds, and other diagnostic information is also always a component of these EHRs. And then Another vital component being decision support, which includes clinical decision support tools such as alerts, reminders, and evidence based guidelines on how to treat and manage a patient. So, implementation of these EHRs can be problematic in that they are expensive and require investments in hardware, software, staff training, and ongoing maintenance of those systems. Ensuring compatibility and data exchange between EHR systems sometimes can be challenging. Yeah, because different systems can be existing in different healthcare facilities, and compatibility issues might always arise. Then protecting information from unauthorized access will always require robust security measures, which sometimes require more investment, and that is always another challenge. And then healthcare providers need to be trained, of course, to use these systems, and sometimes this is also a challenge because it requires time and more resources to do that. So, from all that, we've been looking at health facility based sources, and now let's go into population based data sources. So, these include vital registration, which could be data that is collected on the birth, deaths, marriages, migrations, and these form essential sources of demographic information. But they can also include population censuses, which systematically collect demographic, social, economic data on people in a country at a particular time. And the uses of this of population census data, for example, is that it provides information on the population structure, where we look at the size of the population, the age structure of that population, how which age group has the most people, the sex distribution, males and females, but also goes on to look at to provide insight on geographical distribution and population density, the housing status of the people in that country where the population census has been conducted, the health status, the literacy level, how educated are they, occupation, social status. And from this population census data, we always get essential denominators for calculating rates and population-based indicators, because it is always a big kind of data source, because we can always use them to get denominators for example, maternal mortality, for infant mortality, under five mortality, overall mortality or crude mortality rates. So we get all these from the data that is collected from the population census. And then other population based sources will include surveys, where data is obtained routinely or periodically from communities through surveys to gather information on specific health to gather specific health information. Then censuses, like we've said, is a total enumeration of a population to collect data on demographic characteristics, the population size, its composition, and the changes. Then vital registrations, like we had put, will include documentation on births, deaths, marriages, migrations within a population, providing that critical demographic data. So the importance of a census, like we said earlier, will help us to understand the size, the composition, and the distribution of a population across a given geographical area, and it influences the need and utilization of health facilities. So if we we conduct a census and we see how people are distributed in a particular country, then we are able to 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 get means of putting in place interventions so as to improve utilization and access to these health facilities. And then census data collection will help us to get information on age, sex, marital status, place of residence, literacy, occupation, economic activity, and household relationships in a particular country. Then we said one of the other sources, which is population based, is the registration of births and deaths. And the importance of doing this is that we tend to get data on mortality, and we also know the population that is, whether it is growing or not. So we use this personal documentation to get insights on births and deaths, or people who are related to people who have given these, or who have died or who have given birth, can always do their personal documentation. Sometimes the legal and civic organizations also do this. They document these deaths and births, but also population tracking can always help us to do this registration. The challenges that are faced in this registration of births and deaths is that sometimes it is always hard for people to define the live births and fetal deaths, or the deaths of the baby before being born. And then reporting early neonatal deaths sometimes is always also hard, and lack of motivation in public for the registration. So sometimes people, due to the emotions that are always related to deaths, will always not find that motivation to report the deaths. They don't find it very appropriate, or there is no motivating factor in that time of losing a loved one to report even a death or do registration of death. So whenever such deaths are not captured, then we end up with errors in our registrations. Then morbidity and disability data can also be got from population sources, and these include routine health service records, where we get this morbidity and disability data. So it it this data will be got from the health facility sometimes, and it provides general mobility and disability data based on the medical records and study of the symptoms that have been recorded in those medical records. And then we can also get this data about mobility and disability from routine data collection and notification systems. Yeah, these of course always capture communicable diseases and these cases, and people who have got disability through those infectious diseases can always form this data. And then occupational health institutions will also always provide occupation related morbidity and disability data. How many people are getting disabled due to the work that they are doing? Okay, so these institutions that are engaged in occupation health always have this data. Other sources of this mobility and disability data include the patients groups. For example, if you are in an HIV patient groups, where you provide yourselves with social support on how to live with the virus, then such a group always has vital information that can always be used to get this morbidity and disability data. So they offer this specific data on individual patients. Like I said, there could be a group of HIV patients, and their records are always safe with someone who heads this group. And if you approach them well, you will get that information. Of course, you have to make sure that you're not going to disclose this information to other people, and they also do not give you identifiers of members of this group. Okay. Then the other source of morbidity and disability data could be disease registers, which provides detailed information on specific groups of diseases and or conditions covered by that registry. Surveillance records, which track selected diseases for outbreak detection and monitoring, could also be another source of morbidity and disability data. Then reports from volunteer workers or volunteer organizations sometimes will provide secondary data on morbidity and disability. So these collect data from these patient records, aggregate them, and will always be a source of this secondary data. Then reports from to the Ministry of Health and international organizations sometimes also contain this summary on mortality, on morbidity, disability, and demographic information. So these could be routine or periodic by health facilities in a given country that are reporting to their Ministry of Health. So if you access that data upon request, then you can always have insight on this morbidity and disability. Then mortality data will be got from vital registration systems on deaths and births. So for you there, you'll be focusing on deaths, and it captures data on births and deaths, like I've said. So the vital registration systems always provides essential data on mortality. National sample surveys will gather mortality data through representative sample surveys. So here you do not have to do a census or or or, or count or do counting of all people in the whole country, but you can use a representative sample, and then you generalize on the general population. So these national sample surveys can also be essential tools to gather this mortality data. So you can always pick samples from each region of the country, and then you use it to generalize on the general population. Then special health surveys and hospital records can also provide information on mortality within specific health settings. Notification of infectious diseases, reports on mortality related to these infectious diseases. So these records on infectious diseases also always have that part of death. So if you access this information, it will also guide you on that mortality data. Then government and voluntary health institutions also contribute to mortality data collection. Revenue agencies, police, village or community councils also always record deaths of people in their jurisdiction, and can always be sources of this mortality data. Then reports of national and international organizations sometimes contain disaggregated mortality data and demographic information. So all these are essential sources of mortality and morbidity, which can always be accessed by public health officials to get that information. So lastly, we want to talk about the steps of data processing. After you've collected this data, how can it make vital meaning, or how can it influence decision making? So you have to do what we call data processing, and data processing is a stepwise kind of thing, and it includes steps like data collection, data entry, data cleaning, data coding and classification, transformation and integration, and then data analysis. So in data collection, we collect this relevant health data from various sources, which I've seen earlier on, like medical records, surveys, administrative databases, and research studies. And these data collection methods may vary depending on the type of data that you have and the purpose of the analysis. So you can either use qualitative methods where you want to assess for the knowledge, the attitudes, and practices, and there you will be using majorly those open-ended questions. And then in quantitative, it's more of numbers, so sometimes it's not in depth, but sometimes you can use a mixture of the two collection methods, where you have qualitative and quantitative, so as to have that synergistic effect. Then in data entry, once you have collected that data, it needs to be entered into a system or a database, and this can be done manually by transcribing the information from paper records into electronic formats, or through automated data capture methods. So you can first collect that data, you put it on paper or those questionnaires, or sometimes you use the system itself to collect data and automatically enter the data into the system. Then in data cleaning, you identify and correct errors, inconsistencies, and missing values in the collected data. So here you want to check for data entry mistakes. You verify data accuracy against the source documents. If you have the source documents with you, you want to check if I'm missing a value, or if I'm missing something in my data. Could it be that I missed it when entering? So you go back to the source documents that you might be having, and you see what you missed, and then you can correct it. So that is what we are calling the data cleaning. Then data coding and classification. We realize that health data often needs to be coded and classified so that we can have standardized analysis and comparisons. And this step involves assigning appropriate codes to different variables or data elements based on the coding systems or classification systems. And the commonest include the ICD-10, or the International Classification of Diseases for Diagnosis, and another being CPT, the current procedure terminology codes for medical procedures. So all these categorize diseases, and can always be used to do this coding and classification, so that analysis will be easier. We shall look at analysis in depth. And then the fifth step in data processing will be data transformation and integration. And here, in some cases, data may need to be transformed or restructured to meet the analysis requirements, or to integrate data from different sources. So you want to convert data into a consistent format, to merge data sets and aggregate data at different levels. Could be at individual level, facility level, population level, district level, national level. So all this will form what we call data transformation and integration. And then the second last step will be data analysis, where the data is processed and is prepared. It is and then it will be analyzed to derive meaningful insights and draw conclusions. So depending on the research question or the objective of your survey, Data analysis methods may include descriptive statistics, uh, which which will be which will either be measures of central tendency or dispersion, and this we look at mean, you know, we look at median, the mode, what is the mean age of that population, what is the model age of that population, yeah. Then we also look at things like variance, we look at things like standard deviation, and then in inferential statistics, we want now to generalize our data on the general population, or conclude or make conclusions with our data on the general population using by testing those hypotheses by using techniques like the chi-square tests, the ANOVA tests. All those will help us to infer our data on the general population and make conclusions. And then we can have data mining, machine learning, and other analytical techniques that we shall look at in depth. And then data interpretation. So after analyzing the data, the results are interpreted in the context of the research or the study objectives. So before you start to even do data analysis or to collect data, you need to have objectives of this, of your research or your study or your survey. Yeah, it could be to 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 maybe assess the effectiveness of a treatment intervention or a malaria prevention intervention. So you need to have those objectives in place so that even after analyzing this data, then you can interpret it, and it should be in context with your research objective or goal. And maybe the other step that is worth mentioning is reporting of this data, of this information that you have gathered. So after you've gathered this information, you've analyzed and you have done the interpretation, then now you need to report it to the to the stakeholders that are relevant. So if you want to influence policy, then you're going to report to the policymakers. If you want to improve service delivery in a health facility, then you're going to report it to the health facility administration. So you always state those stakeholders that will need or will benefit from that data collection or your survey and research. So that is it for today. We've looked at health data, the sources of this health data, and how we can process it. So thank you so much for your time, and I'll catch you on the next one. Have a nice day.